Texas Tech El Paso Health Sciences Center. And we're well in the Texas Child Mental Health Care Consortium. That is the statewide organization that is funded directly out of the Texas legislature. We're in the general budget, and it administrates 5 different programs, one of them being CPAN, Child Psychiatry Access Network. And this program today is part of that network to teach the community, educate the community on psychiatric problems so that they can be treated more quickly and in a more comfortable environment for the patient. So we are not the ones as child psychiatrists and therapists that really pick up on a lot of these problems. What happens is someone like yourselves identify this. And so the more you know about, okay, can I treat this myself or do I need to refer it to someone else? So that is the point of the whole educational part of our program. And then, of course, we have the part where you call up and we'll give you all kinds of advice. So today, we're going to be, here, let's see, let me introduce Melissa. You put my name first on this, but really, Melissa has put together most of this presentation, and I'm just going to do the part about medication. Melissa Carrasco Herrera has her master's in education, and she's an LPC supervisor. And that is one thing that we're trying here in our programs is all our LPCs. We are facilitating them to become supervisors in order to help the whole community, because we're hoping that, maybe they're moonlighting and supervising people, but eventually we would love to develop a network or kind of an internship residency type program for LPCAs to facilitate them to become LPCSs with the minimum of problems. We have Melissa and Joyce both got certified as supervisors. So we're very happy about that. All right, next slide.
Ready?
So this is where Melissa is going to start, but I'm going to tell you a little bit more about Melissa.
Okay.
She is currently a mental health clinician at Texas Tech with us, El Paso. She was born and raised in El Paso in the Hidden Valley area and attended Riverside High School, as well as its feeder schools, Riverside Middle and Ascarate Elementary. My husband went to Riverside, and he's quite a bit older than you are, but
mature. He's mature.
He's mature. And we also have a clinic at Riverside. They have a pediatrics, adolescent medicine, and child psychiatry in their clinic, and we are the providers. At Texas Tech is the providers of all 3 services. So she has a bachelor's degree from UTEP in social work and a master's degree from UTEP in counseling. She has dedicated her life to working with adults, adolescents, and children with mental health issues. She has experience working with outpatient mental health services, including the inception of what is now Atlantis Behavioral. That's an outpatient clinic in town, and has worked at the El Paso Psychiatric Center in the Child and Adolescent Unit. More recently, she worked at Fort Bliss with military families as a military family life counselor and conducted resiliency groups with children and adolescents through the DOD EA grant. Prior to coming to Texas Tech, she worked in private practice at the Counseling Center of the Expressive Arts, and while there, worked with patients dealing with trauma due to the Walmart shooting in August 2020. It has been a very, very 2020 and 2021 have been very hard years. So anyway, I'm going to turn it over to Melissa to discuss disruptive mood dysregulation disorder. They give it a really long name, and I really would have given it a much simpler name. But anyway, she's going to tell you all about it, and then I'm going to jump in the middle and talk about the medications. And on slide 20-something, and then I'll give it back to Melissa. So There you go. Thank you so much for joining us, and take it away, Melissa.
Okay. Thank you for coming in, especially during your lunch hour. But I did want to go over it's disruptive mood dysregulation disorder. One of the problems we have is that it's still being researched. It's still very much misunderstood. Pretty much we didn't start seeing that actual diagnosis till after the 1990s. Many doctors were trying to find something to describe the dangerous and the severe outbursts and the temper tantrums that children were having, which were out of the ordinary. So they thought about possibly diagnosing them with bipolar disorder. The problem is the tantrums and the outbursts are not just cyclical, and they don't just happen every now and then. Pretty much these children are constantly having tantrums and are constantly irritable. It's pretty much like both at home and school, walking on eggshells. You don't know what could trigger them, what can set them off, and it's pretty much explosive. They go into rages. Some doctors thought about possibly, instead of DMDD before then, diagnosing the children with rapid cycling bipolar disorder. Specifically, this was studied by Biederman and Geller. The only problem, as I said before, is that there is no cycling. It's a consistent irritability that is always there. And like I said, the irritability is always there, and it's like a ticking time bomb. You don't know what could trigger them, who can trigger them. If you even look at them wrong, they'll go off. And so the appearance of the bipolar was due to the outbursts lasting for hours. Pretty much once they get triggered, it's hard to pretty much control them. And that's some of the problems that we start seeing both at home with the parents and in the schools with teachers. Automatically you think, okay, well, let me go towards the child when they're having these episodes to try to help them out. Like, wrong. Whenever they're in these rages, they perceive someone coming towards them as they're going to be attacked. So one of the first things we say is, if anything, stay away from them, give them as much space as they need, both at home and at school, because you going towards them is going to give them a misperception that you're coming at me, you're being aggressive, stay away. So what you need to do, if anything, is give them the room that they need to do whatever they need to do, both at school and at home. In the classroom, I would definitely tell you, don't try to go after the child to take them out of the classroom. Do the opposite. Leave that child in the classroom and get the other children and yourself out, because they're going to need that silence and everyone out of that room to calm down. It's not something you can really try to control. Same thing in the house. If they're in the bedroom, whatever part of the house they're in, try to get everyone out of the way, specifically any objects, heavy objects they can throw. Because like I said, they're going to misperceive you going towards them and they're going to get more aggressive. So if anything, you and anyone else, get them out of the room. And that's going to actually try to help them calm down as much as possible. The only problem was when they started diagnosing the children with the cycling bipolar is that the insurance companies weren't reimbursing it. They were telling them, why aren't you giving them the diagnosis of bipolar disorder if you're seeing these rages? And so the doctors tried to explain to the insurance companies, the problem is they're not cycling, it's just constant irritability. So pretty much what they started saying was, okay, then let's see what else we can come up with that insurance companies will reimburse for, and understand that these children are not just having bipolar disorder because they're not cycling. Pretty much pediatric bipolar disorder, it does not present with distinct manic episodes as in adults, but instead with severe chronic irritability. And pretty much the DSM-5 specifies that DMDD takes precedence over intermittent explosive disorder. So that was another problem that doctors and insurance companies were having with each other. Intermittent explosive disorder, though, it may be appropriate when the duration is less than a year. Pretty much the person who started first doing the research in the DMDD is Dr. Ellen Liebenloft, MD. Currently, she's a senior investigator and the chief of the section on mood dysregulation and neuroscience at NIMH, which I'm sure we've all seen articles from, journals. They're still doing studies, as you can imagine, but she's the one that really started pushing for the diagnosis change from the early onset bipolar to disruptive mood dysregulation. Pretty much, she started studying the amygdala, specifically the part in the brain which controls emotion and processing. And what she was starting to see, and is still continuing to study, is that there is a possibility that when the children are having these rages, they're looking at the face emotion processing, and that they're particularly fearful of facial expressions. So pretty much during this time when the amygdala takes over these rages, they cannot control what they're seeing or doing, but they're perceiving people's facial expressions and actions as being a threat. So it's like fight or flight. So that's why I mentioned before, whenever these children are having these episodes, leave them alone in the room and you get out so that they can calm down, because it's not at a point where you can ask them nicely to please go to their safe place or do anything, because they're not at a point where they can even control their reactions or what's happening. The symptoms in children are very much different in those than adult bipolar disorder. Pretty much what we say is that 3 or more severe tantrums a week that are inappropriate for the situation, and also persistent irritability or angry moods between the tantrums without sustained periods of relief. So I know it's horrible to think of, but if you can possibly think of being a parent or even a teacher having to try to manage these children, it's very difficult because you don't know if it's a person triggering them, if it's a smell, sensation, anything going on in the room. So pretty much until you find out what is triggering them, all you can do is try to stay away, try to see if you can try to help them control themselves by leaving the situation, and then they eventually come down. The NIMH pretty much came up with DMDD after studying the children previously diagnosed with bipolar. And they're like, yeah, no, there's no cycling with these kids. It's like they're constantly irritable. It's adults and teachers having to deal with this irritability. That's the problem, not so much their cycling. As I mentioned, these children are constantly irritable. It's like walking on eggshells. They may have brief periods where you may see a smile on their face and they're happy, but then it can suddenly switch on you. So it's like walking on eggshells, as I mentioned, where you don't know what could trigger them. They could have been laughing 1 minute, they could have been participating in class, they could have been at home helping you shampoo or bathe the dog, and then they flip on you. The one thing that parents and teachers do say is that the irritability is very similar to that of oppositional defiant and the conduct disorder. The only difference is that the irritability that you sometimes find in bipolar disorder is episodic. So it's representing a change from the person's usual state. And what we usually say is that it actually interferes with their daily living skills at home. And then at school, it actually can also interfere in their schoolwork, because if you can imagine, it's very hard for a teacher to even have class if she can't take him out of the classroom, because if you physically try to get them out, they'll actually be even more angered. And that's where they actually might start grabbing objects around them, both at home and school, throwing them, flinging them. And it's very hard to control, because oftentimes after they have these anger fits, they don't often remember what they even did. Sometimes and often, it's having to take adults or even teachers to try to find out, okay, what triggered you? So we try to keep this from happening. But it's difficult because many times they don't even remember having the fits. They might actually start looking around the room and saying, you know, what happened here? Everything's on the floor and people are looking at them. Many times they don't even recall having these temper tantrums. The DSM-5 diagnosis criteria pretty much is the recurrent temper outbursts that are manifested verbally or behaviorally or even both. And they're definitely out of proportion in intensity or duration. Pretty much you can go from a scale of 1 to 10 in a matter of seconds. Like, as I said, it can be very explosive, where they can just walk into a room after going on a potty break at school or coming out of the restroom, and they start throwing things at you and you have no idea what triggered them. The temper outbursts are very inconsistent with a developmental level. As I mentioned, they're not going to be like the toddlers that throw themselves on the ground, not getting their way. It's the very opposite. It's very much they burst out towards you, start flinging things, saying things at you. And as I mentioned, it's hard to have them process what happened afterwards, because as I mentioned, some of these memories to them, they don't remember what happened. So that's often what kind of interferes with the parents, therapists, and even teachers trying to find out what triggered them, because they're having to go backwards to remember what it was that made them angry, and most of the memories aren't even there. The temper outbursts occur on average 3 or more times a week. So that's kind of what separated them from having the conduct disorder and oppositional, because they happen 3 or more times a week, as opposed to several times a day, hour, month, you name it. Plus, there is remorse with what they did, but as I mentioned, the memory of them done it is not there. And then the mood between the temper outbursts is persistently irritable or they're angry. So it's like they don't completely come down from their high or the temper outburst completely. They're still going to be very angry and irritable the rest of the day. And again, they can be re-triggered to have the same outburst. So that's what makes it very difficult and why a lot of people that were originally diagnosing with bipolar disorder said, no, with bipolar disorder, you actually do come down sometimes to a point of depression. Here, it's like you don't know what can re-trigger them, what can make them angry again, but they're still going to be grouchy or irritable throughout the rest of the day. The criteria is that it has to be present for 12 or more months. But during that time, the individual didn't have a period lasting 3 or more consecutive months. The diagnosis shouldn't be made for the first time before age 6 or after age 18. We do have to take other considerations such as genetic predisposition, if there's any family history of bipolar disorder, if during pregnancy the child was exposed to any drugs, substance abuse. So we need to take other things into consideration. And also what's important is that oftentimes also with DMDD, it's possible for the child to also possibly have ADHD or ADD, which you also have to treat. The presentation will go into it later on also, but it's difficult when you're trying to treat the ADHD and the ADD and the DMDD because it's like you have to make sure that the medications that treat one thing aren't going to trigger the episodes of anger and the irritability as well. So it's really asking the right questions to the parents, the age that they saw it, the types of tantrums they have. And again, one of the factors that's very important is that it actually interferes with their daily living, both at home. And it actually has been interfering with their school to the point where academically their grades have suffered, or some of them have actually possibly gotten in trouble at the school because some schools actually sometimes have to send them home to suspend them, put them in school suspension, or like right now we're in the middle of COVID and a lot of kids have started coming back to school. So a lot of times you might find some school districts recommending that, you know what, I think your child needs to stay at home and do school online instead. So unfortunately, as we know, there's a lot of children that cannot be properly educated online through the computer. And that's where it can further cause them to decompensate, feel even worse about what's going on. Unfortunately, sometimes trigger the irritability even more or even cause the grades to go further down. The behaviors don't occur exclusively during an episode of major depressive disorder, and they're not better explained by another mental disorder. Again, it's re-examining to make sure that there's no genetic predisposition, that there was no family history, getting any kind of information you can during pregnancy, prenatal, so on and so on. And we also need to make sure that the symptoms are not attributable to the physiological effect of a substance or another medical or neurological disorder. Sometimes children who suffer with neurological disorders have chronic migraines, and that in itself can trigger some irritability and anger in the children. Also, the brain chemistry, there can be an increased activation in the areas of the brain specific to controlling aggression and inhibition. So sometimes you might want to make an outpatient referral just to make sure there's nothing going on in the brain that could actually be triggering this anger and the irritability as well. And then, of course, as I mentioned, the family history, there wasn't any substance abuse during the pregnancy. There wasn't any substance abuse around the child, or even that the child themselves or adolescent may themselves also be possibly using substances, which can be triggering the anger and the irritability. Pretty much DMDD is classified as a pediatric mood characterized by the persistent irritable or angry mood and the frequent temper outbursts. Those are the one things that definitely offset and differentiated from the oppositional defiant and the other disorders, only because they're frequent. And as I mentioned, whenever they come down from the temper outburst, they're still angry. So at any point, they don't completely get back to normal, only to a certain point where you're not sure what or when they can be re-triggered. The outbursts usually occur 3 or more times per week, and the mood in between, as I mentioned, is they never go back to normal. They're always irritable. And again, as I mentioned, the symptoms have to be present for the 12 months before a diagnosis can be made. And they have to be diagnosed between the ages of 6 to 18. Pretty much once they're age 18 and over, then we need to possibly start looking at other things going on. And that the tantrums can't be due to autism spectrum. So that's where we also need to make sure that we ask the right questions of the family members, any genetic predispositions, developmental disabilities, or even maybe possibly processing disorders that they may be having in school, which can be causing the temper tantrums possibly at school because they're having problems learning or even a learning disability. And then again, as I mentioned, any history of substance abuse in the adolescent themselves or even possibly in utero during the pregnancy. One of the things is that it has to be present not just at home. It has to be witnessed both the home, school, daycare, different settings, not just one. And also, excuse me, the symptoms usually have to be seen in not just the parents, but often teachers, daycare providers, or people that are outside of the family that can actually say, no, definitely he or she has had these anger tantrums, episodes where they start screaming for no reason. One minute they're happy, they can be having a great time playing with each other, and the next you look and in the room they're just like throwing things, yelling, screaming. There's actually physical aggression towards other. They're not normal for the child's age because they're not common for the children to have meltdowns when they don't get their way. So usually we're used to dealing with toddlers. When you don't give them what they want, they lash out and you see them on the floor and they do it in hopes of getting what they want and getting their needs met. Problem is, you still see these behaviors in older children that are already in elementary school, middle school, before the age of 18. That's something that's not common. And as I mentioned, the outbursts occur 3 or more times a week towards adults, peers, or teachers, or as I mentioned, they can even happen in the daycare. What you are going to notice is that usually prior to the actual explosive behaviors in the child, before they start actually physically getting aggressive and throwing things at you, or they may themselves physically start coming towards you if they perceive that you are going to cause them harm, the child will be moody throughout the day and eventually climax. So you are going to start seeing something different in the child, like, okay, he's already angry, he's already cranky, something's up. So usually at that point, that's when the teachers, daycare providers, or parents know that they're pretty much going to have to be walking on eggshells because anything and everything could possibly trigger them. These are some of the causes that usually are investigated, but as I said, it's still being investigated, DMDD. We're still not sure what possibly could be causing it. It can be many factors, but as I mentioned, usually when you start talking to the parents, you need to make sure you get a thorough family history to make sure there was no substance abuse, the parents didn't have any difficulties during the pregnancy. Sometimes they're starting to look to see if possibly the child is getting proper nutrition. They're looking to see if possibly the child could be deficient in specifically in iron, vitamin B12, or folate. Those are the 3 they're looking at now that they're still studying. And then also, as we all know, maybe changes in the actual life of the child, maybe family divorce, a death, a relocation. As we all know, right now we're going through a pandemic, and it's especially hard for children because they're not even able to go. Well, before they weren't able to go into hospitals to visit their sick family members, such as maybe close grandparents that they were close to. And unfortunately, it's even worse when they passed away and they weren't even able to physically see a body. And unfortunately, some of the funerals have to be expedited because of the COVID. So it's like they really don't have any closure as to what happened to this caregiver. Am I ever going to see them again? Or, what's going on? So it's also having that closure of death or having an inconsistency in their life can also possibly cause some of the triggers of the DMDD. And then, as I mentioned, of course, again, the neurological disabilities, the chronic migraines, or they're having any kind of neurological problems that may be affecting them. And then again, the brain chemistry. So that's some of the things that we take into consideration before we start looking at other factors. Pretty much there is an increased risk of children if there's a family history of DMDD. So definitely, again, it's taking a thorough family history and finding out from the parents, can we find out from grandparents how you were in the school during these ages? Did you have the same problematic behaviors? What did they do to try to help you? And unfortunately, what they've been finding in the studies is that the males are more likely to have DMDD than females, but there have been some females that have been found to have DMDD. And again, as I mentioned, the family conflicts, school difficulties, school suspensions are the ones that affect them the most only because they feel left out of being able to socialize with peers, especially during COVID. But if they get suspended, a lot of times it's misperceived that they can control their behaviors and that whatever they did as far as throwing objects or being physically aggressive towards teachers or even their parents, that it was something they could control. And unfortunately, at this point, the studies show that they're at a point where it's a fight or flight. They misperceive people trying to help them as coming at them, so they attack. And it's not something they can really control because when they're having these fits, they're at a point where they're having they see themselves as having to protect themselves. Pretty much, they found that any children who are not properly treated when they're younger now with DMDD have a high risk for anxiety and unipolar depression in adulthood. So unfortunately, the DMD doesn't go away, but it manifests instead as anxiety, unipolar depression. And they found that a lot of people that they've assessed have voiced that when they were younger in elementary school or in the school system, they had difficulty in the schools, they had these temper tantrums, constant irritability, and anger, so that they have been able to find. Pretty much the people that can diagnose the children are medical doctors, psychologists, or of course, psychiatrists or nurse practitioners. Pretty much they start seeing these children in their clinics when the parents start having the issues, or they start getting called into the principal's office, or start having these meetings with the teachers that the explosions are happening, they're not going away, they're actually throwing objects at other students, and it can actually be harming other people in the classroom. So whenever you do a proper assessment, it has to include observations, not just from the people that see them every day, caregivers, but also teachers, any daycare providers, anyone that has any kind of contact with a child. That way you get a proper evaluation as to, oh yes, I've seen this child having these temper tantrums, but you're seeing that it's a wide variety of things that triggers them. It's not just one certain person, not one certain situation that triggers them. Definitely, I know we can't do school visits right now and interviews, but definitely we can't do them in person, but we can do them through the Doxy or definitely the WebEx to try to find out what's going on within the school system, even with the administrators to try to find out, okay, what is going on that could possibly causing this anger or triggering them to go off. One of the requirements though for the DMDD is that there is a mood disturbance and that it has to be present for 12 months or more. And again, the age, the child has to be between the ages of 6 to 17 years of age. They were present before the age of 10. And again, we've evaluated them and definitely ruled out anything neurological going on with them, any migraines, anything else that might have been happening. Pretty much as I mentioned on the studies that they have done up until now in studying the DMDD, is that it's the amygdala that seems to pretty much take precedence over what's going on in this child or adolescent's brain. It's the controls the body and the thinking and pretty much where the brakes are located. So as you can imagine, whenever this child is going off, the amygdala is pretty much in control. So like, as I mentioned, they become physically aggressive, they start throwing objects, and pretty much eventually, once they eventually come down, again, they don't have any memory of what occurred, what happened, or even what might have triggered them. And that sometimes is what makes it difficult to try to find out how to help them. If you do take them to eventually to a counselor to do CBT or any kind of counseling, they're trying to identify what triggered them, but unfortunately, not even they themselves may know what triggered the actual episode. Fear is a one thing that sometimes these children have whenever they're having these episodes. And it's usually triggered from a response from a traumatic experience, car accident, abuse, or anything that might be going on. But as I mentioned, whenever the children or adolescents are having these episodes, the best thing to do is get everyone else out of the room and leave them by themselves, because at this point it's fight or flight. They're perceiving anything and everyone around them is trying to harm them. If they see that you're just standing at a stance where you're not going to harm them, hands down, you back away, they'll be able to calm down a lot sooner than if they see you slowly and steadily walking towards them. They're going to perceive you as trying to hurt them. And if anything, is going to cause them to be re-triggered or the anger to be even worse. So the best thing to do as a professional teacher, anyone you can talk to, is tell them, back off, get everyone else out of the room, try to take, heavy objects out of the room, and they'll eventually calm down. But it's going to happen a lot faster than if they perceive teachers going towards them and trying to hurt them. And again, I put some illustrations of fight or flight because pretty much, as I mentioned, the amygdala takes over whenever they're having these episodes. Cortisol is getting released and they're just thinking of, okay, I need to keep myself safe. They're going to perceive that a lot faster and come down from these tantrums a lot faster if they perceive they're not going to be attacked, they're going to be fine. And then we'll be able to talk to them in a calmer atmosphere and try to figure out, okay, are you okay? Okay, then bring everyone back in. And then hopefully they won't be re-triggered to have another episode. And then Dr. Martin's going to take over from here.
Okay, there's a couple of questions. I'm going to go over the questions for us so far, and then I'm going to go into the medication treatment, and then we'll go back to Melissa for treatments, other therapeutics.
Okay.
Psychotherapy, etc. Okay, someone in the audience asked, does a family history of bipolar disorder mean a higher risk of DMD? And I would say, and I think this is what Melissa was trying to get at, is if there is a family member that has bipolar disorder, you would just want to look much more closely and evaluate much more closely to make sure that this child doesn't have bipolar disorder. Bipolar disorder is very rare in children, but DMD, so if you had to go by the numbers, put your money on DMDD. If the patient has like a bipolar mother and the mother's aunt has bipolar disorder and you're sure it's bipolar disorder and not borderline personality disorder, which are two things that often get confused, then you would want to keep that a little tighter into your differential. That's what you were getting at, right, Melissa? With the bipolar.
Yes, pretty much, because unfortunately we live in a society where right away they're like, okay, well, my aunt, uncle, grandma all have bipolar disorder, so the child must have it. I'm like, not necessarily. You need to make sure that the right questions are asked and answered. And as I mentioned, remember that the DMDD is you're constantly irritable and you're constantly angry. That never goes away. Whereas as opposed to bipolar, there's a cycle to it. Whereas with DMDD, like I mentioned, it's you're constantly walking on eggshells. So that's one of the things that also helps to differentiate. So that's one thing that you also want to mention to the doctors. They're like, you know what? It's like walking on eggshells. He or she are always angry. They're always irritable. There's no coming down from there. Or they were happy, but then they were triggered off. That's a clear difference from the bipolar disorder.
Somebody asked a question about TBI. So if you have a kid that has a TBI, most providers are going to list that as the primary diagnosis because you might want to add, especially like occupational therapy, speech therapy if needed. So you want to make sure you include that as a diagnosis. If they also meet criteria for DMDD, even after they have optimized the usual treatment for the TBI, the traumatic brain injury, then you might want to consider having that child and treat them as if they did have DMDD, but there's not TBI. Irritability due to TBIs is notoriously hard to treat. But if you have tried the standard things, the kid is still extremely irritable. I mean, they can't go through life like that. The longer they stay like that, the more aggressive they are, and the more trouble they get into, and it can be really disastrous. So if you have optimized that TBI treatment, then I would consider using what I'm about to talk about if all else fails. And it was a similar question about in utero exposure. So the mother's using drugs or alcohol while pregnant. If the child meets a diagnostic criteria for, say, fetal alcohol syndrome, most providers probably put that as a primary diagnosis. And this is probably more likely the treatment that I'm about to talk to is probably more likely to be effective for these kids, even though we have identified the probable cause of their symptoms. The treatments I'm about to talk to probably will also be helpful for them. And people always ask for our slides. I love it when they ask for that. And every presenter that we have had has always been so happy to share their slides with everybody, because that's the whole point of this program, is to share as much knowledge as we can. There's another question. Would these children benefit from being in a smaller classroom or special education setting? It doesn't seem practical to have a teacher remove a full classroom of students repeatedly to allow this child to settle down. Does this create a positive reinforcement cycle that everyone else responds to these tantrums? So that is a complicated question. It's a great question. And, a lot of times these kids, if we can't help them with treatment, that the treatment I'm about to talk about and Melissa's about to talk about, then that can be very helpful, because some kids don't respond to treatment.
And we're going to get in later on in the presentation into the 504 and IEPs. So hang on.
Okay, we're going to talk about that.
Yes.
I'll stop there then, because a lot of times they do get into a smaller classroom, and Melissa's going to cover that. Okay, so here we go. This little cute little picture of the brain, and the amygdala is one of the places, the brain has all these feedback loops, but the amygdala is one place that's identified as being responsible for rage. During the times when the kid's having a big outburst, because it's low level irritability and then big outburst is the pattern. A lot of times they don't remember what they did. So trying to talk through with the child why they got so angry, why they exploded, is probably not going to be that helpful. You want to go before that and see if you can identify something earlier on before they exploded. That's how it's going to be the most helpful, probably. And then there are, so the first thing to say about medications, this is a new diagnosis, although it's not that new anymore. It's 2013, the DSM-5 came out. They're still doing research to see what the FDA should approve for this disorder. Right now, there is nothing approved. So I have to say that. I can't pretend that there is something approved. There isn't. And this is a controversial topic. There's a lot of people who have very strong opinions about how you should treat this disorder. And so what I'm about to talk about is, it's controversial. I'll just say that but my perspective and the kind of the logic I follow when I'm deciding what I want to give to these kids that are having so many problems is I want to do what's safest for the child. And a lot of times what's safest for the child is something heavy duty. But I try to start with the less heavy duty medications first, so we can minimize any side effects that the child might experience. I know all of us have probably seen kids that are on antipsychotics and they're 50 pounds overweight, and it really causes huge problems in their lives, and especially for their physical health. So that's just the path that I follow when I'm thinking. So I'm just sharing with you my own personal thoughts. And I know Dr. DeVargas and I have talked about this topic many times, and she has very similar recommendations that I do. So if you talk to either of us at Texas Tech, this is kind of the perspective you'll get. So the first thing I do is I evaluate for, and anything when I say I do it, I mean, really everyone, all of you providers in our audience, please, you can do it too. That's why we're providing this extra education. So first I recommend evaluating for comorbid disorders and treat those disorders to the best, try to get the best results you can with FDA approved medications. ADHD or impulse control problems. Sometimes kids like this are sensitive to stimulants. So sometimes you need to add clonidine, which is approved for ADHD. I recommend the long acting. It's called, the brand name is Intuniv. It's really just a long acting clonidine, or atomoxetine, which is also called Strattera. Both of those are once a day medications. They are not stimulants, but they are approved for ADHD. We really want to try and maximize treatment for the impulsivity, because impulsivity plus irritability, you know, these kids, they get themselves in lots of trouble. If you need to add a stimulant and the child has had a bad reaction to stimulants in the past, but you still are having ADHD and impulsivity symptoms, you might want to start Amantadine or a mood stabilizer first before you start a stimulant. So that's just something to consider. If you start a stimulant though, and the child's already on a stimulant and has had some improvement, then you might want to increase that dose. Oh wait, can you go back go back for a second? Oh no, this is right. Okay, yeah. And then SSRIs, if they are clearly anxious or depressed, I usually start fluoxetine and see if that is helpful. And for a lot of kids, you can get quite a bit of improvement with fluoxetine. And this new disorder is in the depressive disorders category with the DSM-5. And the reason they did that is because these kids as adults tend to have more typical depressive episodes. Okay, next slide. If you don't get any improvement treating the ADHD and or with an SSRI for an antidepressant, such as fluoxetine, then you might consider Amantadine. So Amantadine is an old medication. In children, it is approved for treatment of flu symptoms, but is not approved for any psychiatric symptom. It is also approved for Parkinson's disease. So often you'll see elderly people on it. And this is not a super common medication. And some people think, oh my God, that's horrible. But you know what? I've never had a patient have a side effect to Amantadine. When you start Amantadine, it either works or it doesn't work. For kids that are a little on the bigger side, you usually I start 100 milligrams once a day, and then I go to, and then if they tolerate that, then I go to 100 milligrams twice a day. If they're getting into the teenage years and a little bit bigger, then if that 100 milligrams twice a day is not effective, then I tend to try 200 milligrams twice a day. But you have to be a pretty big kid. And so in this slide set, I had put the recommendations for starting dosing in milligrams per kilograms per day, but you do need to divide it into 2 doses. 2 doses that are 8 hours apart. So before they go to school and after they go to school is how most people do it. If you have patients that have, and I know you guys, I'm preaching to the choir. If you have patients that don't take their meds or they forget to take their meds, the school nurse, if the kids are physically in school, is by far, they're way better than I'm a parent, and I always forget. Kids that get their medication at school, dang, those school nurses, they are awesome. They never forget. They have their little charts. They do their charts in the morning, at lunchtime, and at the end of the day, and they do a great job. The target dose should be 10 to 15 milligrams per kilogram per day. There's some things I've read about blood levels, ordering a blood level, but good luck finding a lab that does an Amantadine blood level. It's not commonly enough used that most labs probably don't have it. It'd probably take too long to actually be useful. So if you try that and nothing happens, and this is the effects, I usually see the effects in a couple weeks after, in a week or two after starting the medication and getting to that 10 to 15 milligrams per kilogram per day. Like I said, an older, and someone's asking a great question. So to add and not wean if these are not effective. If something isn't effective, definitely take it off. Some medications you need to taper off. Fluoxetine has such a long half-life, you do not need to taper it. It self-tapers. And then stimulants, you do not need to taper either. Other medications I usually do, as far as like Strattera and clonidine. Clonidine, you start 1 milligram a day, 1 milligram a day for 1 week, and then you can go to 2, and then 3, and then 4. And so when I taper people off, I do the same way. And it's so amazing to me always that how little people write about tapering, tapering off. There's a lot about titrating up and not tapering off. So I've tried a lot of different things. Some of them didn't work out. But of course, I'm only going to tell you all things that do work out. So on clonidine, I go 4 milligrams for, all right, they're already on 4 milligrams. So then you would go to 3 milligrams per week, 2 milligrams per week, and 1 milligram per week. So if something doesn't work, that was the best. That was I'm so glad you reminded me of that. Yeah, I definitely taper off. And that does not happen so many times. But it is not you all in the audience that are primary care providers that are the culprits. It is the child psychiatrists that are the culprits. And so and one of the things I always teach my fellows and my residents that we educate here at Texas Tech is don't forget to taper off the ones that don't work. And don't start 2 medications at a time, because then if it doesn't work, or then if they have a side effect, you don't know which one it is. And then there's 2 medications that mother is never going to give to her child again. Okay. So that's Amantadine. And like I said, every medication, at the pharmacy, they'll give you 10 sheets of 10 pages of possible side effects. And really, I haven't, in any of my patients, I haven't seen any side effects. Now, I do not go to like super high doses. The most I've ever prescribed would be 200 twice a day for really like an adult size kid. And sometimes it doesn't work. If it doesn't work, then I just taper it off 100 milligrams a week at a time. Let's see. And then there's another question from the same person. It says, let's see, how long should I wait to see an effect for Amantadine? I usually schedule my appointments like a month apart, but then when I ask the patients, usually by the end of a week or the end of 2 weeks, they see significant improvement. If they don't, they can always call you at 2 weeks, and if it's tolerating it, and then you can go ahead and increase one of the planned increases over the phone. So then when you see them in a month, you will know whether the Amantadine has worked or not. And I feel pretty comfortable using Amantadine because it's approved for the flu. It is approved to very young age, something crazy like 6 months, but 6-month-old, they do get the flu, and they get really sick sometimes when they get the flu. So a lot of the medications that we use in child psychiatry are not approved in children because people don't like to put their children in child psychiatry studies that involve medication. But for things that can kill children, they will. Now, of course, the people forget that the number 2 killer of children is suicide. So, yeah, but to a parent, they're what they see as what they fear for their children has more to do with the flu or epilepsy or things like that. So you'll see anticonvulsants approved down to 6 months as well. And so those are some of the medications that child psychiatrists use too, because they have been tested for safety in children. There's just not a lot of big trials for Oxcarbazepine. A lot of the trials that we teach our residents and are like the mainstay of our profession, the patients are in the hundreds, not the thousands like the adult studies. So anything that you start and you don't get any improvement at all, I would just go ahead and take it off before you start the next thing. If there's now for Oxcarbazepine is an anti-epileptic, an anticonvulsant. It is approved in children also, just like Amantadine. Now, these 2 medications, Amantadine and Oxcarbazepine, do tend to work in tandem. There is like an additive effect. So if the Amantadine doesn't work, if the stimulant doesn't work, I would taper it off. If fluoxetine doesn't work, I would stop it. But if the Amantadine doesn't work and the problems of this child are very severe, you might consider adding Oxcarbazepine. Now, here's the touchy part. There's not any huge study, so some people start with Oxcarbazepine and some people start with Amantadine. I'll tell you, I start with Amantadine because Oxcarbazepine, you have to start really low and then go up and up and up. I should have put the starting milligrams per kilogram, but the target dosing is 25 to 50. But that one, usually you start at 150 a day, then you go to 150 twice a day, and you take it. So it's weeks before you would get to an effective dose, especially if it's not as strong of a medication. Whereas many times I've started Amantadine 100 milligrams twice a day, and it works even without the Oxcarbazepine. But if you get these kids, I know Kim Shoemate in the audience, and she knows what I'm talking about, that we have many kids on this combination because these kids have gotten themselves in big trouble. And so if the kid is if he's going to get kicked out of school, if he's getting arrested because of his behavior, and I say his because almost all these kids are boys, but not. And that's one reason people probably think it's somehow related to ADHD, because that's also affects boys more. So consider using both of them together if you have a kid who's really out of control. And then you might want to add a stimulant. So there are many people that, I should say, I don't know if I should have many. There's some psychiatrists say before giving up, you should try Amantadine, then add Oxcarbazepine or the reverse. And then if they're still impulsive, add a stimulant. And it's probably, in these cases, it's probably safer to add a stimulant after you already have these two on board, because sometimes you do get this kind of rebound effect. Okay, next slide. Okay, last resort, antipsychotics. I'm trying to be as safe as I can with this algorithm, recommending all these things that a lot of people maybe aren't that comfortable with. So I really encourage you all to try the ones on the previous page. But sometimes a kid is having so many problems that they do need an antipsychotic, and they need it now. But if you can wait, if you see that a kid's having more and more problems and they aren't to the level of needing an antipsychotic, please call us and we'll help you. We'll do our calculator, although pediatricians are better at calculators than calculating the milligrams per kilogram than psychiatrists, I'm sure. But we will help you feel comfortable about trying these. I'll tell you, almost all of my patients that I have to put on an antipsychotic have side effects. Almost every single one, whether it's they're feeling sleepy or they're gaining weight or their triglycerides go up. But with those other two medications, you hardly ever get side effects, and you don't get sedation either. You get calmness without sedation. So if you do have to start an antipsychotic, which you definitely will sometimes, you want to attempt periodically to taper the kid off. And so there's one paper recommending doing that every 6 months. Mothers cannot tolerate that. If the first tapering is unsuccessful, the schools and the mothers cannot tolerate that. Oh, somebody asked about the mechanism of action for Amantadine. It is a dopamine agonist, which is very interesting because antipsychotics, most of them at least have an element of dopamine, being a dopamine antagonist. So there's an agonist and antagonist. And why do both work in a situation that is supposed to be the same? Probably the answer is these kids are not all do not have the same illness. Some have something, some have something else. The brain is the last frontier. There's space and there's the brain. It is so incredibly complicated that it's really, the more we know, the better we'll be able to treat these things, but we're really just in the infancy, I would say. Antipsychotics are the psychiatric medication with the greatest chance of harm. So if you want to avoid antipsychotics, call us and we'll help you get fancy, but safer for the kid. All right, next slide. Oh, stimulants. There is evidence that children, I think I already said this part, evidence that children with irritability will have a decrease in symptom with the stimulant. So don't be afraid to try a stimulant, and it should be probably, they're very safe medications. But if you get a negative effect, the kid gets more irritable, that happens occasionally. Don't be afraid to try it maybe later on the treatment, or maybe later when the kid is older. I have a lot of kids, like when they're 5, 6, they cannot tolerate stimulants, but they continue to have more and more problems in school and with their peers. And so eventually later on, we try it again and they do fine, and it's very helpful. And of course, you don't use them with children who have heart or blood pressure problems. It's very common to have these two together, and sometimes the stimulants do help with the irritability. Antidepressants, very small chance of side effects, also can be used to treat irritability. And these are just some of the problems you can have with antipsychotics. Hormone changes, that one is mostly Resveratrol. This is some of the evidence. We're running out of time, so we can just skip through this, but there are studies that show that there are fewer rehospitalizations if you stay on this Amantadine Oxcarbazepine combination. So this guy works with kids who have to go to residential treatment, the kids with the most severe symptoms. And he's been successful with treating a lot of these kids. Okay, next slide. And this is just a summary of the study. Continuing. Next slide. Okay, this is my last slide. Okay, medication may be needed when counseling alone, and if you guys have time to stay, we'll talk about that real quick. Variety of medications are used to treat emotional and behavioral problems. These medications are used to treat the symptoms. They do not change the brain in any significant way, and so basically you're calming the child in the safest way possible while they are sorting out their coping skills. A kid with this disorder must have extremely good coping skills, whereas a kid who doesn't have temper problems doesn't really need that. They can develop their own in their own way, and they're fine. These kids really need help though. And try to avoid the antipsychotics, and call us if you need help. Okay, Melissa, I took up all your time, sorry.
No, it's okay. For those of you teachers and those of you that work with the children, one thing is, as I said, you try to meet with the child to find out what triggered them. This is also why, as a doctor, you also want to talk to teachers, anyone else that's around them, because you try to figure out, okay, they can't remember, but maybe you can. What were they doing? What triggered them? What smell? What taste? What memory? What was going on? We always refer them to do CBT counseling, so that they can help regulate their moods and increase their tolerance towards frustration, so they don't have these explosions, and to try to calm down their irritable behavior. Now, when you're in school, definitely, as you mentioned, you might want to have either a 504 or IEP meeting. Definitely, if the child is already diagnosed with ADHD, they most likely already have one of these plans. But what it is sitting down and trying to accommodate this child so you don't socially isolate them from their peers, and they can still do well in school. So trying to figure out, okay, if it's that they don't understand a subject or schoolwork that's triggering them, then let's give them more help in the assignment or less of a task to do, but yet they're still able to do the requirements necessary in whatever school district they work with. If they need more time for PE, or maybe some more breaks to walk around so they're not always sitting down in one position. Just trying to figure out what works the best for them so they're not always getting re-triggered, and possibly see if we can try to direct them, if possible, tell them, you know what, if you feel this sensation, you're getting angry or irritable and you think you're about to be triggered, give them a safe place in the classroom or in the school where they can go to, where they don't have objects to throw around, but they can have a way to control their behavior, try to calm themselves down before they explode. And then the more that they get used to doing this, the more they'll be able to control the overall behaviors. Again, as I mentioned, you want to remove the child from the settings or situations that trigger the symptoms. Try to figure out what it is that's triggering them. But whenever they're already at the point where they exploded, don't go towards the children. Remove everyone else and all the objects around them instead, because they'll perceive you trying to approach them, as you're trying to harm them. At that point, it's just safer for you to stay back, just keep an eye on them. And as long as they see that you're not a threat or anyone else is going to try to harm them, they'll be able to de-escalate a lot faster. And definitely trying to teach a coping skills through either CBT or even at the school, including that as part of the 504 or IEP, the deep breathing, favorite song, trying to even have some music playing in the background in the classroom while they're doing their work to try to keep them calm. Again, try to keep the child safe, not only from themselves, but other children also safe. If you can, maybe include that as part of the 504 IEP in the school. Have like maybe a teacher buddy next to you and tell them, you know what, he's about to be triggered. Watch my kids, get them out of the classroom, get them in another classroom. They'll be able to de-escalate a lot faster, and then everyone else can come back in and you can continue having class. But try not to stand in a threatening way. Don't try to walk towards them, even if it's slowly, especially with your hands up. Like I said, they're at a point where the amygdala is taking over. It's fight or flight. They see anyone coming towards them, they're going to attack. Stay out of their way. And these are some of the prognosis. As I said, they're still doing studies, both behaviorally, counseling, and with the medications. So pretty much some children outgrow the symptoms while others may inherit the depression and anxiety. But as I said, hopefully the medications along with the counseling can help them. And also they're at higher risk for poverty, violent relationships, nicotine use to help them with the anxiety, and overall risky behaviors in adulthood because they have a hard time controlling their overall behaviors. And then any questions?
All right, let's see. Dr. Shaw says, it seems very inconvenient to move the whole class out. It could lead to more problems and other kids who are disturbed by this behavior. You know, usually this isn't something that you would do every day. It's something you would do to maintain safety in that event. And
Yes.
then hopefully, because it is inconvenient, the school will get together and make up one of these other plans in order to prevent some of these episodes and really help the parents understand that they do need more treatment, and to include primary care, CPAN, therapists. And remember, part of our CPAN program is to help you find therapists who are taking the kind of patient that you want to refer. Almost pretty much every single psychiatric disorder, the treatment is more successful, there are better outcomes, the kids are functioning better if you add some sort of therapy, whether it's family, group, individual, CBT, whatever it is. We highly, highly recommend adding therapy, especially for a disorder like this, where there are no FDA treatments, there are no big studies. And that's one reason I want to really encourage using the safest medications possible. Because really, really what we want to change is to maximize these kids and the family's coping skills. So let's see. Any more questions?
Mm-hmm.
We had a lot of questions today. I love it when we have lots of questions.
Yeah.
It's great. I know that any of you that are in rural areas, you probably are much more likely to treat this sort of patient yourself, or a kid who's escalating really quickly, even in an urban area. It's really hard to get appointments with child psychiatrists quickly. So please help us. You know, this is a program. Please let us help you. Although you'll be helping us too, because of course we can. The more you all call, the more we can. You can forward to the. Or to you at the end, I think it has our name and number and phone number. Sorry, Melissa. And
no problem. There you go.
To help you manage these kids, you can call us every single time they come in until they're stable. And then if they ever get unstable, then you can call us again. We answer the phone from 8 to 5 in the Central Time Zone and 7 to 4 in the Mountain Time Zone. Although I had them change my account so it still rings after hours. And so, because most of the time I do not go home at 4. And at 7 a.m. Bethany's the one answering the phone. So I do, most of the time I can answer the calls even after hours. I do go to bed early. That's the only thing. But thank you so much for joining us today. I'm so appreciative of all of the people that come, and it's great to see the same people time after time. I just love it. Okay, right now on the survey, right now is the time where we're planning the rest of our or the next 6 months. So we have scheduled, I think, up to August what we're going to have, and then but we're planning for the next 6 months after that. So now's the time to get us your suggestions. You can put them in the chat right now about what you want to learn in the future. But thank you all for coming. Here's our counties that we cover. We go all the way down to Eagle Pass down here. And we are starting to do road trips now. So if you want us to come visit your clinic, please just ask, and we'll tell you when we can get down there, and we can do presentations about CPAN, but we can also do actual CME presentations. And it's so wonderful. The CME department moved next door to us in the same building. They're just in the offices, the suite next door. And so we just love working with them and providing all these educational things. So, and thank you for all the thank yous we're getting in the chat. So appreciate it. I so appreciate it. To enroll, you can click on that little QR code if you're fancy and technologically savvy. Sometimes my camera does it and sometimes it doesn't. But you can always just call us, and really all we need, you can call us up and say, this is Dr. So-and-so. I am an MD in pediatrics, and my email address is blah, blah, blah. And that's all we need, because everything about you guys is on the internet. Everybody is welcome to call us. The service is targeted for primary care providers. But we do know a lot about what's going on in the community. And we have people that are starting to call online and telling us about things that they're doing in the community. And I really would encourage you to do that if you're a therapist, because we give out a lot of referrals every week. If you have changes in your practice, we need to know that. Let's say you're moving offices, and remember, we meet with the whole state of CPAN, so I can always pass on the information to the correct CPAN if you're not in our area, because we want to try and get kids in to be seen. It's people always, all age, whether you're a kid or an adult, the earlier you can get treatment for a psychiatric problem, the better. And you know how it is. You write so many referrals for your patients, and either the wait is too long, or the wait is too long, or they don't want to go to see a psychiatrist. I mean, people are scared, they're nervous, but they already know you guys. They know you and they love you. Some of them they've known ever since, the parents have known you ever since they came for their first, well baby visit after delivery. So that's one reason that we really want to encourage you all to learn more about psychiatry, and then let us help you practice. And I'm just appreciative of everybody that helps us. Melissa, thank you so much for your presentation. And it seems like you were in agreement. We could send out the slides. I had a lot of requests for your slides. Okay, great. Maybe I'll try to improve the medication part so it's more obvious, like what goes together, but what should be tried alone. But in the end, if the parent doesn't think something's effective, you're gonna have to discontinue it anyway. So just go ahead and discontinue it. But any questions, please call us. It's myself and Dr. DeVargas that answer usually it's Bethany and Joyce that answer first, and then they'll transfer the call to either myself or Dr. DeVargas. And Dr. DeVargas knows way more than me, so you're lucky if you get her. But I've been doing this quite a few years myself, and I love it when you all call in. And thank you so much for coming. We really appreciate it.